Okay, yeah. So good afternoon again. Now we'll be moving on to something non-surgical, which is neurotoxin use in oculoplastics. So again, my disclosures. I think as ophthalmologists, we should be proud of the history of Botox. As Botox went way back into the 1800s when it was first reported as sausage poisoning. And then later on, Clostridium botulinum was officially reported as the neurotoxin bacterium. And then Edward Shantz in 1946 purified botulinum toxin A. But it was really the ophthalmologist Alan Scott who started using the toxin to treat strabismus. So it was first known as oculinum. And then the FDA-approved indications for blepharospasm and strabismus came along. So, toxins, the Botox was not used for cosmetic purposes, but really to treat strabismus and blepharospasm. So ophthalmologists were really the first to discover using it. But Jean Carruthers, who's an ophthalmologist, and her husband Alistair Carruthers, who's a dermatologist, they discovered the use of Botox because they realized when they were treating patients for blepharospasm, the wrinkles improved. And that's where the emergence, of FDA-approved indications for glabellar lines and so on became popular in early 2000s. So actually Botox for cosmetic use is very, very recent. And I mean, we owe it to the history of ophthalmology. So how does it work? I think we all know is the release of acetylcholine enables the fiber muscles to contract. And then, the muscle fibers to contract in a normal neuromuscular junction. But with Botox, what happens is the light chain cleaves the snare proteins. So the snare complex does not form. And then without the snare complex, acetylcholine cannot be released. So when the neurotransmitter is not released, the muscle is unable to contract. And so without muscle contraction, you don't get the wrinkles. So that's how botulinum toxin works. So we know that there are aesthetic and there are functional indications. I think, like I asked you just now, you're familiar with, the aesthetic indications like for horizontal forehead lines, glabellar lines, bunny lines, crow's feet, and now we can also use it for shaping the nose with a bit of nasal tip elevation, for the DAO and for the platysmal lines and so on. There are also a lot of functional indications. I think for us, like we talked about, we use it for blepharospasm and a bit of hemifacial spasm, bruxism as well, but also we can use it for cervical dystonia, for limb spasticity, for urinary incontinence, bladder dysfunction, lower limb spasticity, and so on. So there are a lot of aesthetic and functional indications. And I think I'm very interested in neurotoxins because even though it's sort of old technology to us, actually the growth for neurotoxin is just going to continue, and there are a lot of new players in the market. So that's where I'm interested in. So in Singapore, we have 4 neurotoxins. I'm not sure in Japan what you have. So Botox is the one we're all familiar with. It's by Allergan and they market heavily. This spot is by Ipsen. So this spot, I use it more for larger muscles like the masseters because it's known to diffuse a lot more. And then there's Xeomin. Xeomin is by Merz. So the so-called advantage of Xeomin is that it's pure and natural. Now a lot of people are worried about antibodies to Botox, and so that's where Xeomin is coming in, increasing in popularity. But I would feel that the effectivity is still slightly less than the rest, but this is just my own personal experience. And then, of course, Nabota. Nabota is something that's coming up very strong because if you look at the complex size, 900 kilodaltons, exactly the same as your Allergan Botox. Because it's just new, just FDA approved, the number of approved indications is of course less, but it's also increasing. In my experience, really the advantage of Nabota is it's much cheaper. Number 2, the onset is much faster, and yet the effectiveness is equivalent to Botox. And of course, now there are a few more coming up. Daxxify, which is known to last longer than all the other Botoxes out there. And then we have Bond-E. Apparently, within 24 hours, you get your full onset. And then QM Toxin, which is a vegan Botox. So there's a lot of new Botox options out there. Meditox, which is from Korea. It's the liquid version of Xeomin, and then the Tibo. So you can see there's a lot more options coming up, and I think that we need to be very familiar with our neurotoxins because actually the administration of toxin is just going to increase. I think before you inject a patient, you just want to ask what experiences they have had. So when I first started my practice, I had a lot of patients telling me that they were averse to Botox because they've tried it with other practitioners in the past, and then they couldn't raise their forehead after that, and they had significant mechanical ptosis. Or they felt that they didn't like their frozen experience. So when you know what experiences they had, then you know, then you can explain to them that perhaps the amount of Botox used was too much. Perhaps the practitioner was injecting too much of the elevators and not enough of the depressors. So you need to understand and let them know that to inject Botox well, you need to know your anatomy well and convince them that to let them try again. And again, you do want to look because everyone has some facial asymmetry. So some brows are a little bit higher here on one side, and then you can address that with Botox as well. And of course, you want to know what are their precise aesthetic objectives. If they think that Botox is going to improve their static wrinkles, then you again have to educate them that Botox is great for dynamic wrinkles, but not so much for static wrinkles. And of course, you know, if they are actresses, because my boss is a celebrity LASIK doctor, we do get a lot of these referrals. You do need to advise them that they should not get too much Botox, otherwise their expressions will be affected if they need to use their face a lot. So again, it's important to know what Botox is effective for and what is ineffective for. So yes, for the dynamic lines like your forehead lines, your glabellar frown lines, crow's feet, bunny lines and mesenteric hypertrophy and so on, your mentalis overaction, persismal bands, you can use Botox. But if they are static lines, you know, a lot of times they point to their nasolabial fold or their marionette lines and ask, can Botox help with that? Then you need to know that there's a limitation to Botox injections. So great for dynamic wrinkles, not so great for static wrinkles. So green areas are wrinkles that respond well, and red lines should not be treated. Be careful in the zones that are yellow because you don't want unwanted effects like adynamic and ptotic eyebrows or even a punctal ectropion. And then of course, red areas, this is where your elevators of the face are. You do want to be careful around there because you don't want any drooping of the mouth and cheek. So again, we need to know when we do Botox, which are the elevators of the face and the depressors. For the brows, we know that the frontalis is the elevator. And that's why it's important not to just, when you Botox a patient, not just wipe out the action of the frontalis. You want to actually treat the depressors, which are the orbicularis oculi, your corrugator supercilii, your depressor supercilii, and your procerus. With that, you can actually get a brow lift rather than a brow drop. And then for the lower face, the elevators are your levator labii superioris, allocanesi, your levator labii superioris, your zygomaticus minor, your LAO, and your zygomaticus major. And then the depressors, again, your depressor labii inferioris, your DAO, and your platysma. So I think you guys do a lot of this Botox injections for glabellar frown lines. What are we targeting? You're targeting the procerus. You're targeting the corrugator supercilii. This is the lateral part of the corrugator. You're also going a little bit deeper and targeting the depressor supercilii. Just be careful because we do get a lot of referrals for ptosis from these glabellar injections from aesthetic doctors if the injection is too deep or if there's some anatomical variation and it travels to the levator and causes a ptosis. So for brow lifts, like we talked about, if a patient, many patients say, oh, can you lift my eyes a little bit with Botox? You can, but there's a limit to what it can do. But what you can do is really to treat the depressors medially, which are the corrugator and procerus muscles, and then give that lateral brow lift to inject it into the lateral orbicularis oculi. So the frontalis, if their aim is to get a brow lift, then you don't overly treat the frontalis, so they can still elevate their brows. And of course, if they have severe brow ptosis, then they probably need surgery. But with very mild brow ptosis, you can actually treat with a bit of Botox. So this is just on social media now. There's so much trends and reels going on that it's quite useful. You can look at these videos and see. So this is Rebecca Gardell. She's showing that you can treat the procerus, you can treat the corrugator, you can treat the depressor supercilii, and then the lateral orbicularis oculi to get maximal brow lift for that. Okay, and then of course crow's feet. I think you mentioned you do quite a bit of Botox for crow's feet, and I don't actively chase it because actually I think crow's feet are nice and some patients like it, so you don't have to do that. But if they want to get rid of their crow's feet, then just understand that you are treating the orbicularis. You want to inject 1 cm lateral to the orbital rim. No need to go more than 3 cm because the orbicularis ends there anatomically anyway. The muscle is pretty superficial, so no need to go deep. Also, this area is highly vascular, so be careful of bruising. You can actually see the superficial veins and so on, and if you do hit a vessel, just give some pressure by a minute or two to minimize bruising. So forehead lines, I think you do a lot of that as well. I think there's a bit of an art to treating the frontalis because if you're too heavy-handed with it, patients actually really hate the effect of the Botox. We do need to understand the frontalis originates from the gala epineuritica near the coronal suture. The muscles then go down, travel inferomedially, and then they intertwine with fibers of the superciliary arch, the procerus, the corrugator supercilii, orbicularis oculi muscle. And do note that the upper portion of the frontalis attaches to the aponeurosis more inferiorly than the lateral part, and there's actually this V shape of about 3.5 cm above the superciliary arch where there's no frontalis, so no point treating there. So there are many ways to do Botox, and I just took this off somewhere. I don't do it this way, but some people just I think for males with very very strong frontalis, yes, maybe this works. But a lot of times I actually like to undertreat because I do want them to have some elevation of their brows still. So what I do is I usually do an M shape sort of thing, so I avoid the center part where there's very little frontalis fibers. And this will ensure that the fine lines and wrinkles are minimized, but yet they still have some brow elevation. So this is just a video showing the markings, so injecting the frown lines and then the forehead. So this part I usually will avoid if the patient wants a lateral flare, but a lot of Asians, we want our brows to be flat, right? Because we don't want to look too fierce. But many Caucasians and Indians may want their brows to have that flare. Then you may not want to give this point, and then you inject a bit more to the lateral brow so that you knock out their depressor of the lateral brow. And then here she just wants to target her mentalis as well as her DAO because she doesn't like the downward turning of the mouth. So you can inject the depressors of the lower face and then of course the masseter as well. So actually doesn't want to chase her crow's feet. I was just showing the crow's feet as a marking. So we're injecting just small boluses. I usually just give 2.5 units, whether it's Nabota or botulinum toxin or Botox. And you can see I'm doing that M-shaped distribution for the forehead. With that, she actually, 2.5 units is very little. So overall, she still can use her forehead, but yet avoid those wrinkles. And then we're injecting the DAO and the mentalis here, and then feel for the masseter, and then inject into it. So I think blepharospasm, I don't need to talk about it. That's how we train. But now that we've gone through all the cosmetic uses of Botox, I think we understand what we're really treating with blepharospasm better. We're really treating the corrugators, the procerus, and then the orbicularis. And what additional parts are important to treat for blepharospasm is that pre-tarsal orbicularis. So this part we really need to go near the lash line and give just a little bit. Remember to go superficial and not too deep. Again, it's a vascular area. Okay, so taking neurotoxins a little further, we can even use it for brow asymmetry. So this is taken from Prof. Kim and Prof. Wu and Prof. Ho's book, where we can inject the depressors of the brow, and you can also inject the elevators sort of to balance the brows when you get comfortable with Botox. So you can see this is a patient that I did a blepharoplasty for. She's very happy post-op, but you can see that there's a bit of brow asymmetry. So I thought, could I just give her a bit of a better outcome? And so we injected her corrugators, and we also injected her lateral orbicularis, and we also injected her the elevator on the front, on the other side. And you can see that I think there's some improved symmetry. So basically, when you understand the anatomy and Botox, it's really nice. You can play with it on the face. Okay, and then of course, some patients, actually it's nice to have that love band, or in Korea they call it the aegyosal. But some people, if they don't like it, then what you're trying to target is that pre-tarsal orbicularis. And you know, when they're smiling or squinting, it can become a bit more noticeable. And some patients have very asymmetrical ones or a larger one on one side, and that's where you can inject it. Otherwise, I wouldn't chase it. So again, 2.5 units inject at the mid-pupillary point, approximately 3 millimeters below the lash line. Single injection is enough, and this is not too deep, just subcutaneous. And you do get some widening of the probable aperture as well. So some people also inject to widen that probable aperture. So, but do be careful if you note that they have already pre-existing lid laxity or excessive scleroshow. This is probably not the best injection for them. So this is just an example. Patient didn't like the pretarsal orbicularis, and then we injected, and you can see it's flattened. So bunny lines, again, is not something that I routinely chase, but if in your aesthetic practice, you will get patients who don't like it and they need you to inject it. So what you're actually injecting is the nasalis muscle. So you ask them to wrinkle up their nose, and then you inject 2.5 to 5 units of Botox per side, not too deep because you just need it in the subdermal subcutaneous tissue. Try to keep medial and then don't go too lateral because you don't want to relax the nearby levator labii superioris alocate nasi muscles because you can get lip flattening or lip ptosis or flattening of the nasolabial fold if you inject too laterally. Yet, that being said, actually, sometimes we do want to target this. This is also known as the Yonsei point for gummy smiles. So some patients don't like it when their mouth opens too big and they have a gummy smile. So these are the muscles that you inject with Botox if you want to reduce that. And again, this area we know is highly vascular, so it's prone to bruising. So do be careful, stay superficial, and if you do hit a vessel, then just apply pressure. Okay, so forehead, I know we talked about it, but now actually in my practice, I'm moving towards a more intradermal injection because I think we see so many patients with brow ptosis or complain of heavy brows or foreheads after Botox. And this is what studies have shown that it's not inferior. That means it works just as well as intramuscular injection because the forehead skin is thin enough to allow some of that Botox to diffuse into the superficial muscle fibers, so it spares the deeper muscles. So you maintain that resting tone required to lift the brow. So Botox has also been employed for skin lifting. I think this is just evolving indications for Botox. And studies have shown that actually it does have an effect on fibroblastic activity. Also skin quality, now we do a lot of meso Botox. Basically, we either use the injector gun or we just dilute it or give very small doses, microboluses of Botox all over, and been shown to improve pore size, laxity, sebum control, and scars. Again, if you see patients coming in with oily face or with seborrhea and acne, you can use Botox as a treatment option. What studies have shown is that it modulates the neuroendocrine control over the sebaceous glands. Also now, interestingly, hyperpigmentation. So dermatologists are using a lot of Botox for this to prevent skin hyperpigmentation. They find that it's because of the anti-inflammatory activity, which affects various cytokines involved in pigmentary alterations. So Botox actually inhibits acetylcholine release by suppressing an alpha MSH secretion, so it results in decreased melanin production. So you can see there's increasing users and indications of Botox. And of course, Botox for lacrimal gland tearing, you probably do it quite a bit in patients who complain of excessive tearing and have used up their options. You can give Botox to the lacrimal gland. Just be careful, stay lateral. You want to avoid the levator. Okay, so again, like I said, on Instagram, on social media, you can find many new indications of Botox every time. Forehead, we've talked about it. You can also use it for the nose. Now they inject it into the dilator nares muscles to reduce nasal flare. And like I said, the levator labii superioris allocate nasi for gummy smile, the DAO because when you want to lift the corners of the lips, and then even the depressor septi nasi if you want to lift the nose tip. And of course, this is just, there are a lot of dosing guides, just be careful. I think this is a little bit high because I do like to undercorrect. Again, you do want patients to maintain their facial expression, so I think that's what really differentiates you from other doctors when patients don't feel frozen but yet able to achieve the aesthetic results of Botox. And you can see that you can use it for the temporalis as well. A lot of times we also give along the border to give a little bit of a lift because you're sort of knocking out the depressor of the face, the platysma, and then also now very popular trapezius, the Barbie tox or the trap tox because they want a slender shoulder line. So thank you, and we just a plug here. I thought there is a oculofacial aesthetic masterclass in Singapore on the 19th and 20th. We'll be covering both surgical and non-surgical options for oculofacial aesthetics. So save the date, and I think Kashima will be coming. I have one last talk. If you all have any questions, I'd be happy to take it.